Speaking of the show, what's coming up?
We're going to be talking about death and dying and options. Should Americans have the legal right to choose physician-assisted suicide, or should we be focusing on managing pain and symptoms through medical advancements?
Stay right there. Sallie Troy, president of the San Diego Hemlock Society, and Dr. Laurel Herbst of the San Diego Hospice will join us to explain both sides of the physician-assisted suicide debate.
Assisted death, euthanasia, or managing the pain. Who decides? A quality of life is different for everyone. Who knows best?
And my question for you, Dr. Herbst, is this. Aren't there times where continued existence, even with pain controlled, is just simply so unacceptable that physician-assisted suicide would be a logical and sensible choice? I think, for example, of what's come to be called Lou Gehrig's disease, ALS. What do you think about that?
I think that all suicide, not just medically based suicide, but all suicide usually comes because the person has no sense that there is any other way out of the situation that they're in. And what we want to offer from hospice care, from better palliative care, from better education, is the third choice. There is not just a decision of live, suffering, or die. There is the idea that there are people who are committed to helping reduce the suffering, manage the symptoms, provide the care, provide the support, and allow what is really the human being to continue to find meaning in life and to find sense about, the third pathway, which is we will address the suffering issues outside of actually killing the patient.
Well, Dr. Herbst, you said choice, and I think maybe you might want to comment on how far choice goes. If a person chooses not to alleviate the pain, assuming that they can, your position would be, too bad, we feel we can, and you will live in spite of what your wishes are, or the opposite side of the coin.
I think that you bring up another component of the issue, which is not what the patient actually is choosing, but the fact that this particular process of physician-assisted suicide involves two people, not just the patient, but also the physician. And as Dr. Priver said, I took a Hippocratic oath. My job is not to kill, my job is to comfort and to heal where possible.
Okay, and Sallie Troy, Hemlock Society, you've heard both sides of the issue. Where do you stand on something like that?
We certainly respect hospice and feel it is a tremendous service to the community. And I facilitate a support group for terminally ill people, and almost everyone who dies who is in my support group has hospice services because we recommend that. And so if they can have their discomfort and suffering taken care of through hospice, great. And
so necessarily, I'm sorry for interrupting, but it doesn't need a physician to help somebody go out. For the Hemlock Society, one can obtain any other assistance to shuffle off the mortal coil, so to speak.
Oh,
doesn't have to be a physician.
That's not that easy. Like, where would a person get the medication? How would the person know what is the proper medication? Many people say, well, if you want to kill yourself, go ahead and kill yourself.
Okay, well,
but where do you get the medication? And only physicians dispense the medication and can write the prescriptions.
Now it gets personal. What would you do if your child was diagnosed with terminal cancer? A very emotional story. Next.
When I used to live in Holland, where euthanasia is absolutely legal, I think it's one of 2 countries where it's legal right now. My 3-year-old daughter, Sophia, she developed cancer in the eyes. After about 8-9 months of searching for eye specialists, they finally diagnosed it as being cancer. By which time it was too late to do very much. We performed surgery, Her eye was removed. In a second surgery, her optic nerve, one of her optic nerves, was removed. Searching for cancer cells, they discovered it had gone past the crossing, had gone into the other optic nerve. And since radiation and chemotherapy were out of the question because of the side effects, the doctors recommended euthanasia at that time. We thought she had had a very high quality of life during the time she lived. And the moment the quality goes below or personally accepted level, then, I mean, there has to come an end to it if that quality cannot be restored. And I'm very well familiar with all possible alternative subjects apart from normal medical procedures. And I felt that there was absolutely nothing that could be done. Because that's a very important point if you decide for euthanasia or not.
In such bittersweet circumstances, are there options to take when a loved one is terminally ill and in pain?
We're back discussing the legal ramifications of physician-assisted suicide.
Dr. Herbst, as a physician, I'm very concerned with the issue of adequate pain management. When I trained some years ago, there were very strict limitations on how much pain medication could be given to a patient. And I've heard doctors tell me that they're concerned about their own safety legally in prescribing the kinds of doses that we often hear are necessary in terminally ill cancer patients. Isn't there a risk to a physician that his or her medical license could be in jeopardy if they truly prescribe what may be necessary in cases like this?
In California, we have very progressive legislation that protects a physician who uses pain medication to treat pain. You have to make a good faith examination of the patient. You have to document the diagnosis. When appropriate, you need consultation from another physician. But there are no limitations on numbers of doses or the size of the doses of any medication that can be used in California.
So you'd be able to reassure our colleagues that as long as they follow reasonable guidelines and document what they do, they'd not be in danger of having their license assaulted by the medical board for prescribing narcotics.
Not only are they not going to be in danger for prescribing the narcotics, there is some serious consideration being given to create danger for not using pain medication appropriately. That there may, in the very near future, be censorship or malpractice actions taken against physicians who do not adequately treat their patients' pain.
Well, this is talking about pain, but Hemlock Society, Sallie Troy, do you have any guidelines as far as someone wanting to die, the fact that they may or may not be in pain, the fact that they may or may not have a quality of life? What is it, or do you draw the line, or is it just, I want to die, so I'm going to die?
Well, very definitely we have people that we will consider in counseling, and that is they must be terminally ill. That is within 6 months of dying with the physician's best diagnosis. And then in any of the laws that have been written, the person must request this physician assistance in dying. Like one man who had hospice service called me up one time and he said, I have hospice service here, but I'm tired of lying in my own excrement. And he said, I can't get out of bed. I can't even use a bedpan. And he said, I was an executive for a large company, and he said, this is no way for me to be ending my life.
Okay, Sallie, so here's the question then. You mentioned 6 months. They're terminally ill within 6 months. Let's say someone has a lifestyle where he'll be lying in his own excrement for years. He isn't diagnosed as going to be dying in 6 months, but he just can't stand to live the way he's living. Perhaps he's blind and he's deaf and he has no use of his limbs and he lies in his own excrement and he wants out. Hemlock Society, yes or no? And then I'd like to ask the same question of Dr. Herbst.
Well, of course, the Hemlock Society does not provide the means for anyone to end
No,
his
your
life.
opinion on it.
But we are only supporting legislation for this. And in Oregon, the person must be terminally ill, and a person who was not terminally ill would be turned down.
So it's not a quality of life, totally, is it?
Well, it is a quality of life for a terminally ill person.
But if they're not terminally ill and they have no quality of life, then the Hemlock Society would probably not be in favor of letting them out of this earthly contract, so to speak.
We would say that they would not qualify under the legislation.
And Dr. Herbst, comment on that?
14% of hospice patients in the country live longer than 6 months. They've been diagnosed as terminally ill. 2 physicians have certified that their prognosis is less than 6 months. And 14% survive longer than 6 months.
But it isn't a question of survival at this point. It's a question of quality of life. This patient that I was talking about.
What I'm saying is we are wrong in our prognosis 14% of the time. And the worst outcome is that the patients live too long.
Okay, I see what you're saying, but if there is someone who has a quality of life that doesn't exist, lying in their own excrement is so very colorful.
They need more care.
You know, there's a bigger issue here, and I want to address it to both of you, and that is our societal attitude toward aging and dying.
And dependency.
When I trained, I have to admit that a patient who was dying was felt to be a failure on our part, a lost cause, and let's move on to the next patient and see if we can't find some way to get them out of the hospital alive. And no further attention was really paid. Isn't this whole physician-assisted suicide really a manifestation of societal attitudes that simply we are not comfortable dealing with aging and dying?
I can see your point of view from why is society bucking this so strongly. And I think that is a big issue there, because the medical profession has been very opposed to this in general. So, but that's why we keep trying to change people's opinions, and like our medical director goes around to medical schools to give courses to students on looking at the patient as a person and not as whether this patient is a failure because he can't cure him.
But there's 2 sides to the equation, though. You have the physician and you have the person who requests to be led out of this life. And Dr. Herbst, while I respect the physician's choice, I choose to be involved, I choose not to be involved. What do you think the percentage of physicians are who, if society was for this, would be happy to go along with it, but because society and our laws today prescribe this, they choose to back off? What would you say overall from your experience?
I don't really know. The physicians that I work with would rather find ways to care for the patients. I think our whole society is very taken with the concept of autonomy and self-sufficiency, and that our biggest problem is in envisioning ourselves as requiring support and help. And part of that is because we don't like to give support and help. We don't want to take care of disabled people. We don't want to take care of people who have to have diapers changed. And so we assume no one wants to take care of us if we're that ill. And so we feel that something like, having the physician put us down rather than live in that circumstance is the only option that the society has.
Oregon has just changed their law, and they tell me that it's being used in only the tiniest number of cases.
And one of the insurance companies in Oregon has now put a lifetime cap of $1,000 on hospice care, but they will pay for physician-assisted suicide.
Okay, well, we're in the thick of emotional issue here. It's an issue that has a personal side for many people. Here's one woman's thoughts.
She was a very private person. She called hospice herself. My children just became involved in the whole process of her dying. They would come home after school, go see her, read to her, give her water. My son would come and comfort her and hold her hand and just kiss her, and she slowly began to deteriorate, and actually she became unconscious. And but they still came. It was my daughter said, you know, I got Grandma's last smile.
Lynn and David and their guests further explore death and dying. What about current laws, legislation? What about insurance?
Hey, deep in debate here. Sallie Troy says physician-assisted suicide offers terminal patients a dignified death. Dr. Laurel Herbst says hospice care is the only truly dignified way to die. What's the answer?
Sallie, at the conclusion of our last segment, you were anxious to make a comment regarding the insurance issue in the state of Oregon.
Yes, as far as insurance companies go, it's not legal for them to put a cap
You
on.
think that's true?
I don't think that is the biggest piece of the issue. I think it was a way of saying, you know, there are ways of manipulating every law. And if we have a law that permits physician-assisted suicide, then there'll be people who take advantage of that law. Maybe not today, maybe not tomorrow.
Well, speaking of laws, though, hey, you know, you take it to its logical end, which is law/murder, especially with the Kevorkian thing that's been happening. Physician-assisted suicide, to some people who are opponents, call it physician-assisted murder. And I would really like to explore a little bit of that before the two of you.
Well, I would like to talk about the murder issue because this is a far cry from murder. If you have murder, you have to have a person killed against his will, and you have to have a victim. And with physician assistance in dying, there is no victim. The person requests repeatedly from the physician that he wants assistance in dying, and this is not murder. And in the law that's being set forth in California, they have actually said this is a death with dignity law. It is physician assistance in dying. It is not to be considered murder. And so that's what the law is going to be in California.
You raise a good point. There are murder statutes everywhere for a specific purpose, and that is to protect me or you from being killed against our will.
I don't think that's what the law
shouldn't,
says.
no,
I
it
think
doesn't.
It says you can't be killed.
But shouldn't it say that? I mean, after all, who is harmed when this act is carried out with the complete agreement and
Your dignity
compliance?
is harmed.
But shall we legislate dignity?
Your dignity is harmed if you don't have physician assistance in dying, according to many people who choose this. They don't want to live an undignified life and go on and on and on because they find being bedridden and being out of control of their bodily functions is not dignified.
But do you hear what we just said, though? Both of you, both of our guests, David, just said your dignity is harmed if yes, and your dignity is harmed if no, physician-assisted suicide. I'd like to settle that.
Who decides
The
what
person.
the dignity is?
The person
That's the
decides.
issue.
Not according to Dr. Herbst.
Well, then we advocate very strongly that the person is the only one that knows whether the dignity is harmed or not. And it's, if some other person says your dignity is going to be harmed and I don't think so, then I have no control. My opinion is not valued.
Sallie, I think what I hear over and over again in this debate is philosophers, attorneys, theoretical debates about what constitutes dignity, about people that they have heard about or heard stories about or maybe even have known. I have taken care of 20,000 dying patients, and I've been there, and I've been at the bedside, and I know what I can do to help patients maintain their dignity during the last days of their lives. We have, in hospice care for many years, been talked about as, quote, the death and dying squad, but what we're about is living during a terminal illness, not about the dying part of it. And I think that more often than not, I hear patients who say, when I came to you, I had severe nausea. I wanted you to give me something to, you know, just make me die because I didn't see how I was ever going to get through this. And when we stop the symptom, the patient then can make some sense out of his life or her life. They can put back together relationships that have been harmed in some way. They can find meaning. And if nothing else, they can see the sunrise, they can hear the birds sing, they can look out the window at a beautiful scene.
But maybe that's something that you might feel is the quality of life,
They
but perhaps
tell
the
me
patient doesn't.
it's quality of life.
Well, but you say that, but yet think about the recent conviction of Dr. Kevorkian. I read the newspapers over the next few days. Nearly all the letters to the editor, from non-philosophers, from non-physicians, from just the average person, were in support of Dr. Kevorkian, that he had done something worthwhile, and that when they reach a point where they feel it's appropriate, they're going to be sorry that they don't have access to this kind of care. So what we're saying is there seems to be a different perspective on this if you're in the profession, if you're looking after patients, versus,
really a patient.
versus whether you are an actual patient. They seem to see it differently.
Well, the people in my support group are actual patients, and they tell me over 100 people have been in and out of my support group in the last 9 years, and what they want is the assurance that if they do not have pain control and if their life becomes unbearable for reasons of loss of control and loss of bodily functions and whatever else is undignified to them, that they have this as an option. Now, very few people, as I said before, in my support group ever elect to do this, but they get a great sense of relief knowing, and some of them are able to get the medication from their physicians. If they have this, then they can carry on with their illness and make a decision at the end.
Well, what about that argument? Physician-assisted suicide should be safe, legal, and extremely rare.
There's so much influence over patients' choices. And I think one of the things that has been a big push for people to make the choice or to say that they want physician-assisted suicide is that they do not have the way to allocate resources to care. And in California, in all of the United States now, there is so much managed care telling physicians what they can and cannot do for patients that in this current environment, I think it would be extremely unlikely that you would not see influence over patients making these decisions based on resource management.
Speaking of influence, one component we haven't talked about at all is the family. That could cut either way. How do families influence these decisions? Are they supportive in general of physician-assisted suicide? I think Lynn mentioned before that is there a danger that the right to physician-assisted suicide could become the obligation to physician-assisted suicide?
It's so hard to see Uncle Joe this way, is what you hear when you're caring for these patients. It's really hard to see him like this. I'm going to project on Uncle Joe my sense of his quality of life, and I'm going to tell him that he has no quality of life living this way, because I can't stand to watch him.
That's sort of unfair. And I understand you've seen the 20,000 plus people. You've been there, and admittedly, I haven't. But Uncle Joe is one thing, and Uncle David is another, and Aunt Sallie is another. Everybody is different. And so to project on most of the people, it's because I want Uncle Joe to buy the farm because I want his inheritance. You know, each person is different.
It might not even be that
Even so,
crass.
Well, now, wait a minute.
You need
Wait.
to be realistic. Each person has his or her own
According
story.
to the laws, like Oregon law and the law that California is putting together right now, this is impossible because only the patient can go to the physician and request a physician aid in dying. No family member can even be a witness. They must take a person who is not involved in the family or anyone who would inherit to be this witness, and then they have to go back after 15 days.
What right in this country has ever been limited to a small group of people?
This is a complex issue, and unfortunately, we're out of time. But we'd like to thank you, Sallie Troy, and Dr. Laurel Herbst for the compelling dialogue.
You're welcome.
So, Lynn, where do you think I stand on this issue?
Well, I have an idea, but you might surprise me.
I just might.
Stay right there. David and I will give you our own biased opinions on what we've heard from our panel, and we might surprise you. But first, more comments from those who have been there.
If a terminally ill person is of sound mind and of sound reason to make a decision about their own life and death, then a doctor would be the perfect individual to assist them in doing so. I have two different opinions about it. One from the side of me that's a Christian, that believes that there may be a form there of doing something against God's will and taking the life of another person. But then I also have the human side, the side that deals with the compassion and feeling that a person has the right to make a choice about their own life.
It's a very difficult choice for both the physician in euthanasia and the family. And to listen to your heart, to feel with your heart, and to develop strength of character and soul is very challenging when emotions run high and decisions have to be made and stress levels are there. It's a very difficult but very individual and very personal choice.
We aren't going to change the fact that people die. What we can impact is how people die. And that's what hospice really brings to individuals. I think of my friends and family who have used hospice care and the dignity that it has brought to them at the end of their life, the comfort, not only physically, but really emotional and spiritually, and the gift that it really brings to families that they can stay together and really focus on what's important.
Think for a moment. How would you feel if you or a loved one was terminally ill? What choices would you make?